make a list of goal settings. What do we want from this child? What are the issues? And then we will go on to Abhay for the management principles. And we will also ask Dr. Khan to summarize therapy point of view, what will be the management principles, and Abhay will tell us what are the surgical management principles. So, Jayant from Bangalore, going back to, you can play the video.
Just keep listening. Of a gait. But in terms of practical decision making, there are 5 things that you need in order to be able to walk efficiently. So that is clearance in swing. So when you swing your leg, you need to be able to clear your foot. Stability in stance. So when you're standing, you need to not fall down. You need adequate step length in order to be able to progress further. You need good pre-positioning of the foot, which means when you land, you need to be able to land on your heel. In terms of those 5 things, first thing you can see is that she has got someone supporting her. So obviously there is something which is affecting her stance face stability. So the reason she needs to hold on to someone is, and if you run that video again, you can see that she's dragging her toes as she's swinging the leg forwards. She's got toe dragging bilaterally. There was another place. You see that? See how she's catching her toes every time she swings the leg forward. So you can see, so she's got problems clearance in swing, she's got problems stability in stance. She's walking very slowly. And I'm sure Dr. Abhay will discuss the reasons, possible reasons behind why she is walking very slowly. She's taking very short step lengths. Okay? And again, there are various reasons why you take short step lengths. And obviously she's got obviously a very energy inefficient gait pattern. The other thing I would like to know is what brings them to hospital now, because that is the primary reason. Because even though we may describe her problem in great detail, the reason they actually came to hospital maybe for a disability certificate. So just give them a certificate and they're happy and they go away. So I'm not trying to make light of the problem, but just to highlight the fact that we need to know, for 12 years they have not had any treatment.
Most of parents, when they come, I'm sure you will agree, in India and other countries they tell us, I want my child to walk normally. That's what they will, their aspirations and hopes.
Sure. And that is very important to know. It's important to know what brings them to hospital, why they are here, and what their expectations are, so that we can clearly tell them at the outset whether those expectations are achievable, and if those expectations of theirs are not achievable, what can be achieved, and whether they will be happy with what. So they have come for some shampoo, and you don't have that brand of shampoo, but you have a different brand of shampoo, and would they be happy using that? That's what every shopkeeper does. Is if they don't have exactly what you have, they will offer you an alternative. And if you're happy with the alternative, then you can conclude the same. So that is the primary discussion, and that is what will drive forward your thinking as you start assessing the case, because all you're trying to do is answer the patient's needs. So presenting complaint is the most important thing, and history of presenting illness. So I would like to know those aspects before we start assessing, because there are lots of things that are wrong with her. So where do you start? So we'll start with the presenting.
From the audience, I would just like to know, what are the primary problem you all think this patient has in terms of goal setting or management of target. We'll start with you. What do you think is a primary problem you want to address in this?
Girl is 11 years old and she is at the moment is supported walking by the parents. So definitely mobility is one of the requires support in the toileting also. So we should, when we are going for management planning, we should definitely ask the parents what kinds of problems they are getting in day-to-day life. And with, as the child has got, as you will see, the child is supported walking, and as doctor said, it is grade 3. GMFCS. So definitely we can help the child to promote the mobility also, because at the moment she is supported walker. Most probably the parents are using roller or some kinds of walker. If they are not using any walker, so with all other interventions we should use the mobility aids also. So the plan we will discuss after getting all the information from the parents. But definitely the child has got potential. We can do so many things with the child.
So how many of you in the audience feel that this child is fine as she is, and we should just maintain her, and this is pure therapy, and now and
I will like also the mother can give her a little comment. आप बताइए इनका जो
वो मेरी बेटी प्रीमेच्योर है, शी इज प्रीमेच्योर बेबी, 6 kg, and 80% doctor said she cannot alive, but 20% chances were there, but she is alive, and now 50% she is dependent, and from the early, she was 9 months old when I came to Dr. Prohin's Nims Hospital, Panchagutta, Hyderabad. जब से वो 9 साल की है, अब वो 12 साल की है, 9 महीने से 12 साल तक कंटिन्यूस फिजियोथेरेपी है, और कोई मेडिसिन वगैरह नहीं है, ओनली फिजियोथेरेपी एंड बोटॉक्स इंजेक्शंस अंडर द एज ऑफ 5 years.
आप फिजियोथेरेपी में क्या कर रहे हैं? आप करते हैं या थेरेपिस्ट करता है?
रोजाना 1 घंटा फिजियोथेरेपिस्ट घर पे आके, एक्सपर्ट फिजियोथेरेपिस्ट है, MPT किए हुए हैं वो आके 1 घंटा डेली बेबी को एक्सरसाइज करते हैं.
क्या?
स्टैंडिंग, हाफ नीलिंग, crawling, all stretchings, and kneel walking, half kneeling, all stretchings and all, everything whatever she need. हम बार बार डॉक्टर साहब के निम्स हॉस्पिटल जाके वो एडवाइस लेते कि क्या फर्दर एक्सरसाइजेस करवाना है, क्या इम्प्रूवमेंट है. वो बैक में बिल्कुल बैलेंस नहीं है बेबी के, नी बेंडिंग है. इसके लिए हम लोग बार बार डॉक्टर रोहित के पास जाके हम लोग एडवाइस लेके जो भी डॉक्टर साहब बोले वही फॉलो करते हैं. तो बस इस हद तक वो इंडिपेंडेंट है अभी, और 5th क्लास में है, स्कूल जा रही है. मगर हम लोग चाहते हैं कि वो इंडिपेंडेंट होना टोटली. अभी वो हर काम के लिए थोड़ा डिपेंडेंट है पेरेंट्स में, और ज़्यादा हमेशा डरेगा रहता है. चलने के लिए गिर जाते हैं, गिरने के चांसेस ज़्यादा है, तो इसके लिए डर के आगे नहीं बढ़ते.
So now the message is that one is an MPT. We are having neuro MPT in Nizam's Institute. So I think if your concern is that which kind of a therapy is being given, just a stretching and stretching and stretching, it is not. It is a neurodevelopmental therapy. If required, our people will come and they will again explain you. So she is on a regular, a motivated family, getting at an institutional guidance, and then carrying it at home. Now with this spurt of growth, again another hiccup that she is started going into crouch, etc., which all we know about it. And as we all know that there is all a spastic phenomena that as soon as some sound comes, we all get. So similarly, she gets much more excited and they feel as if she is much more nervous. So without any surgery, with the therapies, in between a little bit of the botulinum toxin, otherwise nothing much. Now they want a better game. And you know the height of father and the way she is getting the height and the problem arising. Yeah, Dr. Marsura.
तो एक सवाल आपसे जानना चाहेंगे, मेरे अलावा काफ़ी लोग जानना चाहेंगे. जैसे आपने कहा कि इंडिपेंडेंट हो जाए, इंडिपेंडेंट इन लाइफ या इंडिपेंडेंट मोबिलिटी, किस चीज़ की बात कर रहे हैं? बहुत की बात कर रहे हैं, यानी कि मोबिलिटी की बात कर रहे हैं. तो मैं दूसरा सवाल आपसे पूछना चाहूँगा, इस वक्त इस समय मोबिलिटी के लिए क्या यूज़ करते हैं आप? जैसे अभी तो आपका सपोर्टेड है वॉकर, किस तरह के वॉकर यूज़ करते हैं? मतलब वॉकर आगे रहता है, वॉकर पीछे रहता है?
वॉकर आगे होता है और विदाउट व्हील्स होता है.
दिस कैन बी नोटेड आल्सो. और अभी वॉकर यूज करते हैं. और वॉकर से इन हाउस मदद कर देती है, घर के अंदर
हर जगह जाती है,
बाहर भी चली जाती है,
बाहर भी जाती है, स्कूल जाती है,
बाहर भी, मतलब वॉकर यूज करती है.
डिफरेंट हाउस है,
हाँ,
स्कूल भी जाती है वॉकर से. लेकिन कोई साथ होना चाहिए उसको।
नहीं, वॉकर के साथ भी सुपरवाइज्ड है।
हाँ बिल्कुल।
क्योंकि डिसेबिलिटी में एक सेंटेंस है
आउटसाइड हाउस।
हाँ, कि डिसेबिलिटी में कहा जाता है कि अगर एक सेरेब्रल पॉल्सी बच्चे के साथ आप इंडिपेंडेंट की उम्मीद करते हैं तो आप किसी दूसरे को उसके पीछे मत लगाइए, किसी दूसरे को डिसेबल मत बनाइए, क्योंकि एक बच्चे के साथ एक और शख्स डिसेबल हो रहा है ना, सारा टीम। या तो ये एक बहुत इंपॉर्टेंट चीज़ है जो हम जरूर डिस्कस करना चाहेंगे। या एनीवन, या प्लीज
यूज़ किया
जी
है।
बिल्कुल 9 स्प्रिंट्स यूज़ कर रहे हैं और स्टैंडिंग के लिए भी डिफरेंट स्प्रिंट्स है। 2 स्प्रिंट्स है, एक रात में सोते वक्त लगा देते हैं और एक एक्सरसाइज के बाद।
वो घुटनों का या पैर पाँव का पैर का?
पूरा यहाँ कमर से नीचे तक। और सोते वक्त सिर्फ उनके वो नी बेंड करके सो जाते हैं। कमर में भी ऐसे ऐसे हो जा रहे, जैसे कि लोग टॉल हो रहे, जैसे जैसे इनकी हाइट बढ़ रही तो ये प्रॉब्लम अराइज हो रही कि कमर ऐसी हो रही है।
और ये क्राउच गेट जो जैसा नी का बेंड हो रहा है, वो पहले कब से ज़्यादा हो रहा है?
ज़्यादा हाइट जैसा जैसा बढ़ी वो ज़्यादा हो रहा, बीच में नहीं था वो।
हाँ, कितने 1-2 साल से हो रहा है?
3 साल से हो रहा।
3 साल से।
12 साल।
Because they're the ones who do all the assessments all the time.
So, anyone from therapy group who wants to come and?
Is there any, so not the, have you got that? Okay, so this is one. I think from my point of view, what I would want to look at are 3 categories. One is strength. Is she strong all the way down? Or are there any levels of weakness in your physical exam slide? Ability to stand, you need to know the grade of strength, which is from 1, 2, 3, 4, or 5, and that will have to be done at every level. And it has to be looked at very carefully because sometimes spasticity will mask weakness. And if you then have some anti-spasticity treatment, you will expect. Second thing, so first is strength, so that's what we need to find out. The second is true contracture. So on your next slide, so the next slide, if you go forward, no, maybe, so this one, so now just back one. Back one. So what we have here is just one line saying that there is terminal contracture of both tendo Achilles and hamstrings. There is one missing component. Which one might it be? Which is the third joint? Yes. So, but just knowing about the knees and the tendo Achilles isn't really that relevant. The next point I'd like to make is that when you see her stand, right? What is the position of her ankle joint? Dorsiflexion. So how would you accept that terminal contracture of the tendo Achilles if the range of dorsiflexion is maybe 20 degrees, maybe 15? So you have to be a little bit careful when somebody presents physical findings like this, because you have to say, is that what? Which are the muscles that insert into the tendo Achilles? The gastroc and the soleus, right? And so we know that the function of the two and the action of the two is different. One thing is pretty obvious, that she has a very long soleus, because that is the range of dorsiflexion in the ankle. Can you expect the gastrocnemius to be long as well? The answer is you don't know. So that is one of the things that you have to try and find with your clinical examination, which is why I was asking, what do you want to know? Could the gastrocnemius be tight? Anyone who says yes? And why might it be tight then? Why might the gastrocnemius have a contracture in spite of the fact that she's walking in crouch? There is a distal effect, which is the midfoot break, and that may be because of the way the hindfoot has gone into valgus and allowed the gastroc to maintain its length. What about the other side? So the knee is flexed as well. So you now have to start working out with the gastrosoleus. I don't like using tendo Achilles because it's non-specific. with the gastrosoleus, we may have a physical finding of a long soleus, but possibly a contracted gastrocnemius, which has an effect both distally and at the knee, because it inserts proximal to the knee joint. So that's one level. The second is the contracture in the knee. Now, what components of that would you like to know? Because these are basic physical examination findings, really. So, in your assessment that you had there, you've talked about the Tardieu scale for the hamstrings, correct? So, that part of the examination is telling us something specifically about the hamstring muscles. But the hamstring muscles are again two joint muscles. So we don't know, yes? Correct. So you don't know whether the hip has an effect on the knee or not, because all these joints work in concert, as it were. The second point around the knee is to know whether there is any fixed flexion, contracture, or deformity of the knee, which is what, if you worry about the hamstrings, which other muscle group should you be equally worried about? Quadriceps. And what are the things about the quadriceps that you would like to know? So one big good point is about the rectus. And was there something on the video that told you about the rectus?